Hello, I am Dr. Mirela Cernăianu, and I welcome you to the Wellness Optimizing Warrior MD podcast, the WOW MD podcast. I am not your typical wellness coach, and this is not a typical wellness podcast. Here, I'll discuss educational facts about health, hormones, intimacy, anti-aging, and beauty trends, all very hot topics, to empower you to make great choices when it comes to your health and to your body. I want you to go, wow, I did not know that. Or, wow, this is going to make a great difference for me. Our healthcare system is broken and it needs a revolution. You and I can start one today. I am willing to share my knowledge with the world if you're willing to listen. Let's get started. Hello, listener, and welcome back. Today's episode is mostly about oral estrogen. And I believe this type of episode is really important, and it is a very widespread use, unfortunately, of replacement therapy that many doctors still recommend, hopefully less and less. And many women are currently using oral estrogen in multiple forms. And granted, this episode and this podcast is geared towards hormone replacement therapy, but everything I'm going to talk about actually pertains to any synthetic oral products, and especially birth control pills, which are really widespread amongst women. So, as I promised, let's continue talking about the best method of hormone replacement therapy. And as I told you in a previous episode, there are some really key factors you need to take into consideration when choosing a hormone replacement therapy method. So first of all, the question is, what do we need to know and understand about hormone biology and physiology in order to empower us, women or men, to choose the best method? Well, basically, the best replacement hormone method would actually be the one that gives you the best, steadiest circulating blood levels. So I will definitely talk about that today in this podcast. So coming back to how to choose the method. Well, the more information and data we have, and the more in the know we are, the better the choice we're going to make. So whatever method you choose, know that when the hormone is administered into your body, it will need to enter your body and linger in your bloodstream and be circulated around to all the cells, tissues, and organs that need it. So that means it needs to go to all the cells that have receptors for that hormone on their surface in order for it to have the desired effects and actions. So if the hormone is not circulated around, it won't really work very well. Also, once it's circulated, it has to interact with the receptors. And after its interaction with the receptors, then now what? Well, we need to get rid of that reaction. Otherwise, we're in trouble. So this process raises three issues you need to be aware as a hormone customer and consider when you make your choice of hormone replacement therapy. Number one, I just said we need the hormone to enter our body, linger in our bloodstream, and be circulated around the cell tissues and the organs that need it. This is called bioavailability. Number two, the hormone that you are replacing, estrogen, testosterone, progesterone, thyroid, needs to interact with specific receptors in order to activate those receptors on the target cells, which is needed in order to cause the desired results. Let's call this a biocompatibility issue. Number three is the safety issue. Once the receptor has been activated by the hormone you're replacing, you need a process and a pathway that is allowing you to detoxify from that hormonal presence in a way that ensures replacing a hormone and introducing it artificially into your body on a daily, weekly, monthly basis is actually safe for a long time, whether it be years or decades. That is bioelimination. So we have three issues to consider when choosing a hormone replacement therapy: bioavailability, circulating it around to the target cells, biocompatibility, adequate interaction with the target cells, and bioelimination. Is it safe for us to use this type of hormone for years or decades? So I bet you these are 3 issues you never heard about in a consultation and that your doctor never discussed with you, but they are very important in how you choose your method. So let's talk about number 1, bioavailability. Well, we need the hormones to enter our body and somewhat linger. We need them to be present and circulate in our blood so they can go to the cell tissues and organs that need it. And some of those tissues need it in a constant, steady fashion. For example, if you're using hormone replacement therapy to improve vaginal health, you ideally will need to have circulating estrogen levels that will interact with the receptors on the vaginal tissues in a consistent, steady fashion, like 24 hours, 7 days a week. If you provide your body with hormone levels, and this hormone circulates in your body only for maximum 6 hours a day in that 24-hour window, when time comes to introduce a new hormone dose, and in those few hours, those levels are extremely low, very low, or moderate, it's extremely unlikely you will feel significant results. You might get some improvement, maybe minimal, maybe moderate, but you'll still suffer the dryness, the pain. There still will be some symptoms. Let's say you're using the hormone replacement therapy to improve your mood. Well, you might not know, but it is crucial that you need to have circulating hormone levels 24 hours a day, 7 days a week, because your neurons, your brain cells that are in charge of how the mood operates. Do you have good mood, bad mood, blah mood? These interaction, which involves neurotransmitters and is very complicated, it's crucial to have hormones in a steady fashion because the brain cells keep going and interact constantly with each other. And there's neurotransmitters being released all the time. And they're target receptors on all our specific brain cells for estrogen, progesterone, and testosterone. So when the body has these hormones naturally, these hormones are bathing the brain pretty much all the time. They don't get released with a high peak and then nothing afterwards. More on that in a little bit. And another example is if you need stronger bones, then the receptors on the osteoblasts, the cells that need to make new bone, will need to be constantly activated and stimulated to continue to make new bone in a continuous fashion. And the balance between removing old bone and building new bone needs to be maintained at all times by continuously making new bone, destroying old bone. So this process needs to be constant. So being exposed to an anabolic hormone that builds bone, whether it's estrogen or testosterone, for a few hours a day or a few days a week will not necessarily give you this benefit of improving bone mass. So these 3 examples I provided really refer to the bioavailability of this hormone that's being replaced. So remember this term and maybe ask your doctor next time a hormone replacement therapy is recommended. Say, doctor, what is the bioavailability of this method? They might be a little stumped. It's not something we normally discuss with clients. So what is bioavailability? Like I mentioned before, the amount of hormone that is being absorbed and circulated, the time that this hormone lingers and is present in our blood circulation, allowing it to get to the target cells and the tissues, the amount of time that these tissues are exposed to that hormone, all of these together is called bioavailability. So in other words, bioavailability is the extent to which absorption of the hormone occurs from wherever you introduce it to the body. Refers to the fraction of the administered hormone that would actually reach the systemic blood circulation in its pure, unchanged form, the form that needs to interact with the target cells. And it refers to the proportion of the hormone that enters the circulation when introduced into the body, so it is able to have an active effect. And that's something that we actually call free estrogen, free testosterone. So now that I established what bioavailability is, I would like to talk about the bioavailability of all the different hormone replacement methods, which is a crucial factor to take into consideration when you make a decision about what is the best method for you. So I mentioned there are various synthetic versus natural types of hormones, bioidentical, non-bioidentical. So now let's talk about what are the methods with the best bioavailability. So I'll discuss each method, but in this podcast, I'm going to discuss mainly oral estrogen and oral progesterone. There are no oral formulations available for testosterone in men and testosterone in women. So let's talk about oral administration for estrogen for women. If you are a woman in menopause and you are taking estrogen orally by mouth in the form of a pill, please listen carefully because you need to know what I'm going to talk about next. We have known since 1990s that oral estrogens have minimal systemic bioavailability, about 2%, maximum 10%. And this is mainly due to the gut and liver metabolism, what we call the first pass effect. So let's pause and think about this for a minute. Only 2%, maximum 10% of the estrogen dose that is ingested in an oral tablet makes it to the blood after it passes through the liver. That means a huge amount of that dose, 90 to 98%, doesn't even make it to the circulating blood to be carried around to the tissues that need it. So 90 to 98% of the dose that we ingest if we take an oral estrogen is not bioavailable. So what happens to the rest of the estrogen if only 2, maximum 10% of it makes it to the target cells where it's able to be circulated around? We have known for a very long time that high concentrations of estrone are achieved with oral administration of estrogen. I've talked about estrone in my previous podcasts. It is not a good estrogen. It is a bad estrogen. And I'm gonna just stop here about what estrone is. If you'd like to know more about it, please go back to the excess estrogen episode where I talk more about this specific issue. So if you're taking oral estrogen, specifically estradiol, all you have to do is ask your doctor to check your levels of estrone. You will likely have very little estradiol and very high estrone. What's interesting is that, again, very few doctors know to check for estrone. And that's not necessarily their fault. No one trained them in hormone replacement therapy. Like I mentioned before, a lot of physicians prescribe hormone replacement therapy based on information and knowledge they receive during a symposium from a drug rep. This is how I used to do it, maybe from an article, but it's not that there is any formal training. Our medical system offers minimal or zero training. Once you're out after med school or residency, nobody teaches you about HRT other than what you personally seek to gather. And unfortunately, formally during med school or residency, at least 20 to 30 years ago, there was no formal training in hormone replacement therapy. Maybe there is now. I doubt it, because it seems to me that the younger physicians are even less informed than the more experienced physicians. And the more experienced physicians that are conventional OBGYN doctors, they really haven't received any formal training in hormone replacement therapy. It really was not in the curriculum. So please, coming back to you, ask your doctor to check estrone alongside estradiol levels. And that's another sad fact. Many doctors don't even check levels at all. They just give you the pill, see you later, come back in a year to get a refill. Let's go back to oral estradiol. I mentioned the first pass effect. Let me clarify what it is. When estrogen is swallowed, in addition to being exposed to enzymes that convert much of it to other forms of estrogen, I mentioned estrone, which again is a bad estrogen, the liver also produces quite large amounts of a binding protein called sex hormone binding globulin, SHBG. You might see that on the blood tests if the doctor orders it. SHBG binds to a large part of the oral dose of estrogen, rendering it inactive and further reducing the effective dose. So we got enzymes that convert it to the bad estrogen, and then we got this sex hormone binding globulin that binds most of the active estrogen, rendering it now inactive, reducing the effective dose. And this is exactly how we go from 2% bioavailability, maximum 10%, after ingesting an estrogen pill. Let's talk a little bit about just taking a regular oral medication. Tylenol, ibuprofen, Celebrex, aspirin, all of these medications have a studied, clear-cut half-life, which is the time it takes for the blood level of the drug to reach half of its peak level. All these medications that are taken for the purpose of alleviating pain, inflammation, blood pressure lowering medication, including hormone replacement, and that applies to thyroid as well. What's typical for all these oral medications and drugs, including oral estrogen, is that once the capsule or the tablet enters our digestive tract, it will be processed and released into the bloodstream very quickly. You will have a significant peak, which is an elevation, a sharp, acute rise in the levels of the drug or the hormone that you're replacing. This high peak gets circulated fast throughout the body and distributed to the various tissues that need it pretty quickly. So your tissues get hit with a lot of hormone or medication for a few hours, and then that's it. It is done. There are no more hormones and no more benefits to the target cells. So the receptors in the target tissues for hormones will no longer get stimulated or activated, at least 12 to 16 hours in a 24-hour window. The way I see it, and I like to describe it, is your target cells get hit with a hammer instead of slowly being steadily based in a normal, steady, on-demand circulating level of hormone or medication. Being hit with a hammer is not how the body does it naturally, whenever it releases the hormone. The body makes hormones on demand, and when young and healthy, your body optimally makes hormones 24 hours, 7 days a week, obviously with some variability if you're a woman and you're having a cycle. But however, in a 24-hour window, your levels of whether it's estrogen, progesterone, or testosterone are likely to be pretty steady. But that is not what you get by replacing hormones orally. If you don't believe me, it's very simple to put this to a test. You simply take your estrogen tablet at night, go to the lab in the morning to get your estradiol level. Most likely it will be under 40, which is typical for menopause. So you likely have no lingering hormone levels at 12 hours after you've taken your dose. If you take your estradiol in the morning, simply go to the lab in the afternoon around 3 to 4 p.m. and you'll have the same result. You have low estrogen as quickly as 6 to 8 hours after you take the oral estrogen. Since I mentioned blood levels, as a side note, let's talk about estrogen blood levels for a second. What is an ideal blood level for estrogen for a woman? I mentioned this before, but let me mention it again, because I'm talking about menopause levels now. When you were young in your 20s and early 30s, you most likely had higher estrogen level than as you get older later in life. Your estrogen levels were likely over 200, maybe even 300 around ovulation. After the age of 40, maybe even in your mid-30s, estrogen levels start to lower, and they're likely going to be under 150. And in your mid-40s to early 50s, they can be as low as under 90 or 80. So what is an ideal level that we need when we are at menopause? We're using hormones, and we want to know if the medication, the method that we chose, is effective. What should it be? Well, again, this is a very maybe nebulous answer, but the level that gives you the best relief with minimal or no side effects is the level for you. So let's talk about that for a second. Most women are happy when their estrogen levels after menopause with replacement therapy is somewhere between 50 and 100. Occasionally, I have women that need to be over 100. And if you think, well, that might be too much, consider what we just talked about a little earlier, that your estrogen levels used to be much, much higher when you were younger. And now, even though you're replacing it and it looks like it's 100 or more, you're still nowhere close to where you were when you were younger. Ideally, someone would study this specific subject or topic. What is the ideal hormone level at menopause? Is there a level above which, if exposed to decades, you might have a higher risk of something? Cancer, stroke, heart attack, etc. So far, the data that we have available does not indicate that there are any higher risks associated with higher versus lower level than just the usual risks that occur as we get older, which we have anyway. Hormones or no hormones, those are the risks for the big four: cancer, dementia, stroke, and heart attack. There is an argument to be made on the side of doctors and patients that have been using these hormones for decades, that when there is a significant benefit to the client's overall health, mood, sense of well-being that makes them want to continue using these hormones, then they should be safe to be used for decades. Because as we get older, the risk for the big four, cancer, dementia, stroke, and heart attack, are there. And they're likely going to be there whether we use hormones or not. And if this is where the big divide is, if you ask doctors that use hormones, they would say it decreases the risk for cancer, dementia, stroke, and heart attack. And if you ask the doctors who hate hormones, they will tell you it increases the risk of cancer, dementia, stroke, and heart attack. Unfortunately, the science and the data is not on the hormone hater doctors' side. It's on our side. Anyway, so let's end the side note with the levels. Let's come back to the subject of bioavailability, and let me give you some facts that are really well known and established. So this little excerpt I'm going to tell you now is from Wikipedia. All you need to do is search for pharmacokinetics of estradiol. Administration of a troche containing 0.25 estradiol via oral route results in peak estradiol levels of about 450. Pay attention, 450 at 1 hour post-dose in postmenopausal women. After this, estradiol levels decrease to 60 at 4 hours post-dose and to about 15 at 12 hours post-dose. And that's exactly what I told you earlier. You have a huge peak, high dose, that's your hammer, that comes and hits you 1 hour after you take the pill, doesn't last long. The estradiol levels drop quickly. 4 hours, they're 60, and 12 hours, there's nothing. Now, if you use continuous twice daily administration of 0.25 milligrams of estradiol via the oral route, once every 12 hours, so morning and night, peak estradiol levels at steady state after the last dose are about 500. That is high, and your cells do not need to be hit with a hammer. But that's what's happening. The rapid rise and the steep fall of estradiol levels with sublingual or oral administration of estradiol, interestingly enough, is very similar to when we do IV estrogen or we administer it intranasally. So neither one of these routes is ideal or healthy. So let me come back to the point I was trying to make when I talked about taking a medication or a hormone and its bioavailability. How long does this medication or hormone need to circulate in your bloodstream to be available to have a cellular or a tissue effect? Well, if you take it orally, it's only going to be a few hours at best. and it's going to get hit with a large hammer for 1 hour. You are literally going to be hormone bombed, and then there's nothing for the majority of the 24-hour interval. And you take the pills twice, morning and night, you just get hormone bombed or hammered twice a day. So ask yourself this very simple question. If we keep bombing our body with these hormones or hammering them for a few hours a day, how safe is this? What if you do it for a few years or for a few decades? What do you think happens? And that's what I want you to think. What do you think happens when the tissues, your tissues, get flooded with this hormone for a few hours? Do you really think that our metabolic pathways will be able to handle such a high peak exposure on a daily basis with no long-term risk? Wouldn't it make more sense, and wouldn't it be safer to just get steady, constant exposure to much lower levels? I'm not going to give you an answer. I'm going to let you decide. At the beginning of the podcast, I mentioned biocompatibility. The hormone needs to interact with specific receptors. And clearly, the bioavailability of a specific hormone determines how much interaction the hormone is going to get with the receptors on the target cells. If the oral hormone has poor bioavailability, it will be present for a very limited interaction and will have limited effects on the target cells. The ability to interact adequately and fully and optimally with the receptors that we naturally have in our bodies for that hormone is what I call biocompatibility. The hormone you decide to use or the hormone your doctor prescribes will work better if it's biologically compatible with the receptor that's being targeted. And this is one of the reasons why the proponents of bioidentical hormone replacement therapy argue that it is superior to non-bioidentical therapy. In other words, expect estradiol, your bioidentical hormone, to act differently than estradiol valerate or estradiol acetate. This seems logic and intuitive. So when you use some of these hormones, synthetic, non-bioidentical estrogen hormones, and that applies to testosterone as well, not only the effect on the target cell could be different, but very likely the body will be able to metabolize the bioidentical hormones faster with fewer risks and side effects since they are chemically compatible. Again, let's call that biocompatibility. And that ties into the bioelimination, which is, again, last but not least, our hormones need to be detoxified and eliminated because we expose ourselves daily, weekly, monthly by using hormone replacement therapy. And this detoxification and elimination is done via very specific pathways. So think about this for a minute. The body already has in place pathways that are meant to deal with the hormones that are our God-given hormones, the bioidentical hormones. It knows them, it recognizes them, so it will very easily handle them. Well, what happens if it's a synthetic, non-bioidentical hormone? I really don't have the answer to this, and no one really does. But logically and intuitively, we can presume, and we're probably going to be correct, that the bioelimination of a non-bioidentical hormone is more difficult, likely not as efficient, as these hormones are foreign. They're look-alike chemical structures that maybe I'm planting a seed here, and I'm asking you to think for yourself. Maybe they could linger for years past their use because the body cannot safely get rid of them. Well, ask yourself this question. When you get bombed or hit with a hammer and you have these huge peak levels, where do you think these hormones go to? They're not going to be in your blood. They're only in your blood for an hour. And the receptors for the cells only have a limited capacity to absorb and interact. So where does the rest of the high dose, this acute elevation in the blood level, what happens to it? Well, it's not in the blood. It doesn't keep circulating. It's only there for 2 hours max. So these hormones, because they're steroid hormones, are lipophilic. They have a high affinity for fatty tissue. They will likely be stored in your fat. So interestingly enough, consider the possibility that as a woman and a man, your breasts could have quite a bit of fat tissue. And likely the concentration of receptors for estrogen is higher in your breast tissue and in the fat cells around the breast tissue. So when you trigger the bomb, the hormone bomb, that high peak, the oral estrogen will give you, where do you think this estrogen hormone is going to go first? In the end, the million-dollar question is, could daily use of long-term hormone replacement therapy or oral synthetic estrogen in general increase your risk of breast cancer? And I'm including the birth control pill in this question. And the answer is yes. We know this. So I did a little research and I was interested to see what is the correlation between using the birth control pill and increased risk of breast cancer. So I came across some very interesting data. If you use Google to search for the country with the highest incidence of breast cancer, it is actually Belgium and the Netherlands. If you use Google to search for what is the usage rate for hormonal birth control in Belgium, the top entry at the top of the Google page says that in 2018, 48% of Belgian women used the pill and roughly 26% of them used the IUD. That is a total of 74% exposure to synthetic hormones. If you use Google to search for the usage rates for hormonal birth control in Netherlands, the top entry at the top of the Google page says, trends in Netherlands show a stable prevalence of modern contraceptive use between 65 and 70% among women aged 15 to 49. So 70 to 74% exposure to synthetic hormones in Belgium and Netherlands. If you do the same search for United States, shows that 25% of women aged 15 to 44 currently use contraception, pill, as their method of choice. And when I did the same search, I came across another result saying that in 2015 to 2018, 65% of the 72 million women aged 15 to 49 in the United States were using some contraception, but the most common one was female sterilization, 18%. The oral contraceptive pill was only 12%. The long-acting reversible contraceptives, which are Nexplanon and IUDs, were 10%. So, interestingly enough, United States does not have such a high risk of synthetic estrogen use for birth control pills. Now think about when breast cancer actually happens. For most women, it happens past their 50s. It does not happen when they're young. It doesn't happen when they have plenty of hormones naturally. It happens after menopause. So what happens during their reproductive life for 20 to 30 years previous to menopause that increases their risk for cancer? Maybe it's using synthetic hormones, as the use of birth control pill and the recommendations and prescriptions for birth control pills increased significantly in the past 40 to 50 years. And that coincides to perhaps the increased incidence of breast cancer rates that we have seen. I don't know if that's the true correlation, but it's an interesting thing to look at. Another thing you might want to consider, because I told you earlier, the hormones are likely going to be stored in your fat as soon as they get hit with the hammer, because there's only so many receptors that are available in the target cells to absorb them. So if they're in your fat, consider the possibility and the consequence of what happens when you lose large amounts of weight quickly. You will potentially release some of these hormones into your circulation, and that might lead to some unplanned consequences, like irregular periods or suddenly you bleed for no reason, etc. So there's lots to think about. I felt it was important to dedicate a podcast to the dangers and potential hazards, as well as the risks that are lurking behind oral estrogen. I personally believe we should not do unto others what we don't want done to ourselves. I would never use oral estrogen, so I don't recommend it to my patients, especially not for hormone replacement therapy. The safest route for estrogen and testosterone hormone delivery is transdermal. Please come back next week when I will talk about transdermal options for estrogen and testosterone replacement, keeping in mind the same 3 things we always need to consider when choosing a method. What is the bioavailability? What is the biocompatibility of that method? And what is the compatibility with the body's natural elimination and detoxification processes, the bioelimination? I will leave you here and hope to see you next week. If you liked the information you heard and you'd like to hear more, please subscribe and follow my podcast. Should you find the content helpful to not just you, but possibly others, please share it and feel free to leave us a review. You are welcome to join the Facebook group, The Warrior Optimizing Wellness MD. I certainly hope that you've heard many things in this podcast that made you go, wow, I did not know that, or wow, I'd like to know more. So keep listening and I'll keep talking.